chapter 13, and we'll go over the third region of our brain, the brainstem. Okay, remember from last class, we talked that there were 4 regions to the brain. You have the cerebrum, and then you have the diencephalon, the cerebellum, and we have our brainstem. So the nice thing is the brainstem is going to connect the other 3 regions to the spinal cord, the second part of your central nervous system. We will learn, all right, that as we go through the brainstem, and it might not be readily apparent as of this chapter, but definitely when we go over chapter 14 and we learn the different pathways, we're going to learn about these conducting tracks, what we call ascending and descending tracks. It's just another way of saying sensory and motor tracks. Because remember, sensory information brings sensory input from the periphery, okay, from the outside, and even from the internal structures in your body up to the central nervous system, up to your brain. So therefore it's called descending or ascending. And then when you are going to initiate some sort of motor control, whether it's skeletal muscle, smooth muscle, or cardiac muscle, all right, that motor information is going to travel from the brain and spinal cord down to your peripheral, your effectors. And so we call those descending tracks. Right. In the brainstem also, we're going to see structures that we call autonomic nuclei, in case you forgot what a nuclei is, right? Aside from the fact that it is the control center in the cells, a nuclei, when we're talking about neuroanatomy, is a cluster of cell bodies in the central nervous system. So the autonomic nuclei are going to be part of the autonomic nervous system, you know, the part of the nervous system that's in charge of respiration rate, heartbeat, blood pressure, digestive activities, right? These autonomic nuclei are located in the brainstem. We'll also have the nuclei of our cranial nerves. The cranial nerve is a nerve that comes off of the brain. And then some of the reflex centers, we'll talk about all that. So we break down the brainstem into 3 regions. We have the midbrain, which is the superior most part of the brainstem, the pons, and the medulla oblongata, which is the most inferior portion of the brainstem. The medulla oblongata eventually becomes contiguous with the spinal cord. So here you can see a nice anterior view of our brainstem. Notice we put the diencephalon on top like an ice cream cone, right? Like 2 scoops of ice cream, just kidding. All right, so you can see you have your 2 thalami here, and then just below it, we'll have our midbrain. And then just inferior to that is the pons, and then inferior to that is going to be the medulla oblongata. You can see all these nerve structures coming off of the brainstem, and those are our cranial nerves. And so we'll go over some of those. All right, looking at the brainstem from the back side view here, you get a better view, all right, of the thalamus, of the diencephalon. We can even see the pineal gland sitting back there. If you recall, the pineal gland was the gland that secretes the melatonin, helps govern your sleep-wake cycles. Here you can see the nice midbrain structure here. And then below it, here's the pons, and then the medulla oblongata. So we'll go through all these fun structures, or at least most of them. So let's start off with the midbrain, the superior most portion of the brainstem here. And the first structures that you're going to notice are going to be the cerebral peduncles, and they're part of our pyramidal system. And again, we'll cover this more in detail in chapter 14, but that has to do with our motor tracks. And motor tracks are descending tracks. And specifically, these type of motor tracks will carry voluntary motor commands, which means that these motor tracks are going to influence and innervate skeletal muscle system, skeletal muscle tissues. So these motor commands are initiated in our primary motor cortex. And if you recall, The primary motor cortex was found in the frontal lobe. Actually, it's right there in that gyrus that sits in front of the central sulcus. We call that the precentral gyrus, also known as the primary motor cortex. So as I'm moving my cursor around and drawing things, right, those first initial nerve impulses, those action potentials, right, originate in the primary motor cortex. And they'll travel right down through the pyramidal system there and those pyramidal tracts, right, all the way out to my hand and innervate my skeletal muscles. All right, another structure is called the superior cerebellar peduncle. Now, there's 3 types of cerebellar peduncles, and each individual cerebellar peduncle will attach to a specific region of the brainstem. So the midbrain's on top, so the superior cerebellar peduncles are going to connect the midbrain to the cerebellum. We'll talk about the function of the cerebellum here in a moment, but the cerebellum is that little miniature brain that sits on the back of the brainstem. Then we have a pathway here called the medial lemniscus. Right? It is made up of ascending, so if we're dealing with ascending tracts, that means we're dealing with sensory information. And so it's this sensory input that travels in this grouping of tissue called the medial lemniscus, which is actually myelinated axons. And we'll see the medial lemniscus run all the way through the brainstem, so through the midbrain, the pons, and the medulla oblongata. Now, one of the more significant structures in the midbrain is going to be our substantia nigra. Easy to spot because it has this area where you see a dark appearance of tissue there, and that's due to the melanin in that area. But what's most important about this area is that the cells there produce dopamine. Dopamine is a neurotransmitter. It plays a role in some of our sensory functions, and it also plays a role in motor movement. So dopamine is going to be used in movements. For example, you've seen, right, folks with Parkinson's, they have a decrease in dopamine. Right? We will see a degeneration of those neurons there in the substantia nigra, which decreases the dopamine output. And so you'll see folks with Parkinson's have what we call resting tremors. Okay, so they'll just be standing there talking to you and their hand will be shaking. And they might not even notice this. And that's a resting tremor. That's a sign of Parkinson's disease. And that's because that neurotransmitter dopamine is in low supply in that area there. We'll also see dopamine, right, used in emotional responses, pleasure and pain responses. So in late stages of Parkinson's, folks may start to exert some different types of behavior and personality changes there. All right, also in the midbrain, we have this region called the tegmentum. Now, before I go and show you that, I just want to show you what I've already, what we already covered here on our, on our transverse cut here of the midbrain. So you can see here's the midbrain right up through here. Here's the diencephalon, and then our midbrain is right here. The pons is right below it. So I'm going to take a cut right through the middle, and you can see here's the part that really stands out. The substantia nigra, darkly stained because that is where our melanin is located. You can also see the medial lemniscus here on either side. That's myelinated axon, so it's going to have a white appearance to it. And then here in the front, you can see the cerebral peduncle. And our cerebral peduncle is going to carry those descending motor axons here. All right. I went too far. There we go. The tegmentum, the cerebral aqueduct, and the tectum. All right. The tegmentum is going to be this area right here that you'll notice there's 2 structures there. Okay, we have this darker gray structure called the reticular formation. We'll be talking about that later on in this chapter. And we also have our red nucleus here. All right, but the tegmentum is this area between, all right, the cerebral peduncle and the substantia nigra, all right, all the way over here to the cerebral aqueduct. It's this region here. Whereas in the posterior part, we have a structure that's almost similar, right, in name. It's called the tectum. We'll talk about that in a second. But right now, we're going to discuss what the tegmentum is. All right. So our tegmentum plays a role in motor movement, but specifically for postural motor control. And if you notice, there's a hole here. Whoops, wrong way. This guy right here, there's our cerebral aqueduct. And the cerebral aqueduct is this tube-like structure that connects the third ventricle with the fourth ventricle. Now, today in lab, we'll go over the ventricles, okay? But the third and fourth ventricles are filled with that cerebral spinal fluid. And then surrounding the cerebral aqueduct is this tissue called the periaqueductal gray. And the periaqueductal gray has, again, to do with motor movement here. All right, then we can see we also have a couple nuclei. Remember a nuclei, cluster of cell bodies, for cranial nerve 3, which is ocular motor, and then our cranial nerve 4, which is our trochlear nerve. Both of those have to do with movements of the eye. Then posterior on the midbrain, we've got this structure called the tectum. Right? And it looks like from the back side here, it's almost kind of like a square-shaped structure with 4 mounds or bumps. We call that the tectal plate. Well, the pair of bumps on the top, those are called the superior colliculi. And they have to do with our visual reflexes and tracking. So if you're sitting at a tennis match or even a volleyball match, and the ball keeps going back and forth over the net, they're volleying back and forth, and your eyes are tracking and following that, you're going to be utilizing the superior colliculi. The bottom two, those are called the inferior colliculi, and they have to do with auditory reflexes. So if you're quietly studying in the library and I'm standing about 10 feet away from you, behind you, and I call your name, hey buddy, and you turn to see where that noise is coming from, you are now utilizing the inferior colliculi to help with those auditory reflexes where you heard something and you turned in the direction of where that sound was coming from. All right, the second area or region of our brainstem is called the pons. Pons means bridge. It's found in between the midbrain and the medulla oblongata. It sits directly in front of the cerebellum. And so it looks like this kind of bulging or bump on the front of your brainstem here. So we'll see, all right, some structures there, but also we're going to see both ascending and descending tracts or sensory motor tracts that are going to be traveling up from the spinal cord towards the brain. So here we'll see the middle cerebellar peduncles, and that's going to connect the pons to the cerebellum. An important structure is called the pontine respiratory center. Helps regulate, all right, the skeletal muscles during the breathing process. So when this area here is functional, it's doing fine, you'll have a nice, easy transition while breathing, okay? Now, if you damage the respiratory center here, the pontine respiratory center, I should be specific, you'll still be able to breathe, but it won't be as smooth and methodical. And I know you can't see me, but it'll be, you'll have a harder time, okay, with controlling those skeletal muscles. So your breathing will appear a little bit more labored. It won't have that smooth transition between breaths. Right, in the pons, we'll also see a structure called the superior olivary nuclei. Again, here's a structure that helps with sound, for sound localization. So when you hear something, all right, you're going to be utilizing this area to kind of hone in and see, all right, the source of or where this sound is coming from. And then we have a couple cranial nerve nuclei here. Now, cranial nerves can be sensory only, they can be motor only, and some are mixed. They'll have both sensory and motor function. All right, so the cranial nerves that we see here in the pons, we've got cranial nerve 5, which is known as trigeminal. Cranial nerve 6 is abducens. cranial nerve 7, which is facial, and then cranial nerve 8 is glossopharyngeal, excuse me, vestibular cochlear. Glossopharyngeal is cranial nerve 9, but that's not in the pons. All right, so cranial nerves 5 through 8, we'll see here the nuclei are going to be located here in the pons. So here's the pons, right? This nice anterior bulging region here of our brainstem. And you can see a couple structures in here. You can see it's right in front of the cerebellum. So what connects the cerebellum to the pons is going to be the middle cerebellar peduncles right here. We'll see part of the fourth ventricle, more on that. All right, when we get into the lab section, we'll talk a little bit more about the fourth ventricle, but that's where the cerebrospinal fluid is going to be located. And then you can see, all right, some of our medial lemniscus here. Again, that's an ascending sensory pathway. And then we have our pontine respiratory center here and here. And we'll also see some fibers of the pyramidal tract that has to do with voluntary motor movement. And I know I keep showing you parts of the reticular formation, and we'll talk about that in a few moments. And then we have some of the nuclei here for our cranial nerves. All right, probably my favorite part of the brainstem is the medulla oblongata, because it's a little guy. It's not a really big area of the brainstem, but there's just so much important stuff here in the medulla oblongata. I have to say, it is probably one of the more important parts of your brainstem, if not one of the more important parts of some of the regions besides, well, the diencephalon with the hypothalamus. Anyways, there's a lot of important stuff here. So the medulla oblongata, also known as the medulla, is the last part to our brainstem. Then inferior to that, it will transition into the spinal cord. So again, we're going to see an area in which we'll have ascending and descending tracts. So the ascending are our sensory, our descending are our motor. So those tracts will pass through the medulla oblongata up into the brain or down into the spinal cord. So on the anterior-most area here of the medulla oblongata, you have these structures, all right? They're kind of these small little bulges or ridges called the pyramids. They're going to house the cortical spinal tracts. Those tracts originate up in the cerebral cortex, in the primary motor cortex, and they descend down into the spinal cord. These are the tracts that are responsible for voluntary motor control. So the effector organ of these tracts are going to be skeletal muscle. Now, what's important here is this is where we are going to see, not all, but most, right, of those axons are going to cross from one side to the other side of the medulla oblongata. Remember what we said, right? The left side of your brain controls the right side of your body. Well, in this situation, we're going to see where some of, I shouldn't say some, but most of these axons will cross over. And that area where they cross over, we call that the decussation. That's what decussation means. It crosses over. So the left motor cortex is going to control the right side of your body, opposite side of your body. Then lateral to the pyramids, we have our olives. Again, these are bulges also. Now they play a different role. Instead of having descending tracts, they have ascending tracts, right? Sensory information, namely proprioceptive information. Proprioceptive information basically tells your central nervous system what your joints are doing. We find proprioceptors in joints, in the muscles of joints, and the tendons of joints. And basically, it tells your brain, if your eyes are closed, if your knee is bent, if your knee is straight, if your elbow is flexed or extended, if your shoulder is abducted or adducted. That's what proprioception does. It tells your brain, right, where parts of your body are located in relation to itself, or the midline, or whatever you want to use as your point of reference. Okay, so your eyes are closed, you have no idea. I mean, if someone's moving your arms around like a marionette, like a puppet, All right, no problem. Your eyes are closed, but those proprioceptors are going to be sending information to your brain saying, okay, your elbow is now flexed at 92 degrees. All right. Also, we have some structures called the inferior cerebellar peduncles. We know what that is. That's going to connect the medulla oblongata to the cerebellum. So each region or each part of our brainstem has its own little connection to the medulla oblongata. Now let's get to the good stuff. Not that any of that stuff wasn't good stuff, but I like talking about the autonomic nuclei. Okay? These are going to be part of your autonomic nervous system, your autopilot nervous system, stuff that is going on as you're sitting here listening to me, as you're sleeping, all right? Well, your cardiac center, vasomotor center, our medullary respiratory center, and look at all these other centers that are located here in the medulla oblongata. All right, so of course the cardiac center is going to regulate your heart's output. Now you're going to learn in 211, right, how we measure that and what exactly is the output, okay? Your heart rate and how forcibly your heart contracts affects its output, how much blood it's putting out. Well, the cardiac center regulates all that. It can increase the output or it can decrease the output. Your vasomotor center is going to regulate blood pressure because it influences the diameter of your blood vessels. It can vasoconstrict, make the diameter smaller, and when it does that, it will increase the blood pressure because it makes more resistance, or it can cause vasodilation, which will then decrease the blood pressure. So you get to learn about all that fun stuff in 211. Hopefully you'll have me. All right, the medullary respiratory center. This is your primary breathing center. Controls your breathing rate, increases it when you're exercising, decreases it when you're sleeping, for example. So you have these two groups, the dorsal and the ventral group. Again, you'll learn about their roles later on. And then it also will get input from the pontine respiratory center. So you have that nice, smooth transition. All right, so a lot of things are happening here in the medulla oblongata. All right, in addition to that, you'll see centers for coughing, sneezing, vomiting, salivating, swallowing. All right, some of those are going to be part of the digestive system control also. In addition to the autonomic nuclei there, we're going to see some cranial nerve nuclei. Right, there's 12 pairs of cranial nerves. In the pons, we saw cranial nerves 5 through 8. So we'll also see some nuclei for the vestibular cochlear nerve. So for the glossopharyngeal nerve, which is cranial nerve 9, vagus, one of my favorite cranial nerves, cranial nerve 10. Then we've got our accessory, which is cranial nerve 11, and then the hypoglossal, that's cranial nerve 12. This next part here, again, you'll learn about this a little bit more in chapter 14, okay? But the nucleus cuneatus and the nucleus gracilis are going to receive what we call somatic sensory information. Somatic is the information that you can consciously perceive: temperature, vibration, touch, all right? So the nucleus cuneatus and the nucleus gracilis are going to be these areas, all right? Specifically, a nucleus is a cluster of cell bodies, and we'll see synapsing going on. So some of the neurons that leave the nucleus cuneatus or the nucleus gracilis are going to ascend up towards the brain through the medial lemniscus, all the way up into the thalamus, and then eventually on to the somatosensory cortex. Good news, we get to learn about that in the next chapter, so we can save that. But just keep in mind that that is located here in the medulla oblongata. So I like this picture because it shows us several different things. And part of me wishes that we almost covered chapter 14 before covering this material, because it'd make a little bit more sense to you. All right, you can see we have several nuclei here for our cranial nerves. All right, over here in the center, these are the pyramids right here. Here's one pyramid, here's the other pyramid. And this is where we're going to see the descending, all right, voluntary motor control fibers coming from the primary motor cortex. This is all going to be for the skeletal muscle. So they'll descend down through the pyramid. And what we're going to see is some of these fibers, and a majority will decussate, will cross over. Some will stay what we call ipsilateral. They'll stay on the same side. Eventually, they'll cross over in the spinal cord, but they eventually do cross over. Most will cross over here in the pyramids, and then a few will stay on the same side, then they'll eventually cross over. Right. The ones that do cross over, right, they become part of the lateral cortical spinal tract. The ones that stay ipsilateral, that don't cross over until they get to the spinal cord, those are the anterior cortical spinal tracts. So again, we'll cover this next chapter, right? Not to worry. All right, then you can see back here, where are we? All right, there's our medial lemniscus. And nope, I don't see the nucleus cuneatus and the nucleus gracilis on this one. No worries. Okay. Here you can see, there they are. There's the nucleus cuneatus and the nucleus gracilis there on the posterior portion there. All right, these are going to be when the ascending tracts come up from the spinal cord into our medulla oblongata here. And then those nerves will synapse here, and then they'll ascend up through our medial lemniscus there. All right, that's it for the spinal, for the brainstem. On to the third region of our brain. No, wait, the fourth region, excuse me. The brainstem was our third region. All right, the cerebellum. Before I get into the cerebellum, all right, briefly, I just want you to keep in mind that the cerebellum is going to be the area or the region of the brain in which we are going to fine-tune muscle motor movement. All right, I shouldn't even say muscle motor, but any type of movement, all right, will be fine-tuned thanks to the cerebellum. And we'll get into that. First, a little bit of anatomy here, okay? So in our cerebrum, the folds that we saw in the cerebrum, we call those gyri. Well, here in the cerebellum, we call them folia. So they're like miniature gyri. And so just like in the cerebrum, we had a left and right cerebral hemisphere. Well, here in the cerebellum, we have a left and right cerebellar hemisphere. We'll have anterior and posterior lobes, right? But in between our cerebral hemispheres, we have a structure called the vermis. And the vermis is going to receive ascending or sensory input in regards to our torso, right? The movement in the torso, but also just balance. All right, balance. When we talk about balance, there's a couple things that we need to consider when you're talking about balance. One is proprioception, and the two is your equilibrium. Balance is just a kind of a general term, but it includes proprioception and equilibrium. And so here, that sensory input is going to come into your cerebellum in regards to movements of the torso and just balance in general. So when we're talking about the three regions of the cerebellum, right, you have the outer gray matter, very similar to what we saw in the cerebrum. We call that the cerebral cortex, the outer gray matter in the cerebrum. Well, here in the cerebellum, we call it the cerebellar cortex. And again, it is gray matter. And then internal to that, we're going to have our white matter, but we call that the arbor vitae, the tree of life. Right? That white matter that's internal to our cerebellar cortex is called the arbor vitae. And then throughout some of that white matter, we'll see pockets of gray matter, and those are going to be our cerebellar nuclei. All right, so we already saw the cerebellar peduncles, just a quick review. All right, 3 tracks that connect the cerebellum to each part of the brainstem. Okay, the superior cerebral peduncles are going to connect the cerebellum to the midbrain. The middle cerebellar peduncles are going to connect the cerebellum to the pons. And then the inferior cerebellar peduncles are going to connect the cerebellum to the medulla oblongata. Right, so each of those parts of the brainstem get their own little connection to the cerebellum. So you can see it, this picture here showing, I'll go over here to the right first. Here's the anterior portion, the posterior portion. All right, you have the folds here, there's the folia. Then over here on our right, that's our right cerebellar hemisphere, and then our left cerebellar hemisphere. And then in between the two hemispheres, we have our vermis, and then what divides the anterior portion of the cerebellum to the posterior portion of the cerebellum is that primary fissure right here. And when we dissect and look inside, you can see the gray matters on the outside, very similar to what we saw when we were looking at the cerebrum, and then the internal white matter, we call that the arbor vitae there. And then we'll have, all right, our nuclei scattered throughout. All right, so let's talk about the cerebellum. Okay, like I said, when I started talking about this topic here, our cerebellum is going to be, right, the part of the brain that is going to fine tune, make sure that these movements become more fluid, right, not herky-jerky. And this will fine tune our movements here. So basically, it's going to help with correction or corrective pattern movements here. And the nice thing about it is the cerebellum is another place where we can store some of our motor movements. So we talked about last class how we have our primary motor cortex, and then we have an association area called the premotor cortex, which sits just in front of that. And that's where we store some of our muscle memories. Well, guess what? Now the cerebellum is another place where we can store muscle memories for some of those learned movements, skilled movements, playing the violin, playing the piano, maybe juggling. All right. So again, another storage site for learned movements here. And so it will help to regulate both voluntary and involuntary motor paths. Important to know that, not just the voluntary, but the involuntary. Helps again with maintenance of balance, equilibrium, posture, all that fun stuff. So what it will do is it will constantly be getting information, and I'll show you a nice picture here, from different parts of your brain, from the cerebrum, from the spinal cord, constantly getting biofeedback, proprioceptive biofeedback from your joints, right, to this area, so we can make sure that if you're doing any movements, that it's nice and smooth. That's what we love. So it helps to maintain that equilibrium, that posture there, because we're constantly getting that proprioceptive biofeedback there. And then it will process that information, right, as it gets motor information from your motor cortex, while also providing sensory feedback. It's really cool. So basically, it's just one big error correcting station. And so it plays a role in all of that integration of that motor movement input from the primary motor cortex and the premotor cortex. So here's that picture I was telling you about. Kind of cool. So here you go. You can see here in your primary motor cortex, right, and from the premotor cortex, it's sending information down towards the spinal cord, okay, out to the body for the actual movement, where at the same time it's sending some of that motor information here to the cerebellum. And so the cerebellum can process that information. That's what these little green arrows are, processes that information, analyzes the information, and then it'll send its sensory input here, right, or that corrective feedback input up to the motor cortex. Then it can make its self-adjustments. Meanwhile, during this whole time, it's getting biofeedback through proprioception from the joints and the skeletal muscles near those joints and the tendons of those skeletal muscles. So there's a lot of sensory and motor input and output coming into the cerebellum and then going up and down to the cerebrum and then back down to the spinal cord. The point of this picture here is just showing you, all right, this is a flowing scenario here, ever fluid, right? And we're just making adjustments to movements. That's how you improve when you're practicing, right? If you're starting to play the piano and a year later, you're much better, is because you've established a lot of these cerebellar pathways through all this biocorrective feedback information that you get. Okay, so our first clinical view of tonight is the effects of alcohol and drugs on the cerebellum. All right, so essentially, if you've been driving, let's not even say that. Let's just say you're watching a movie and a character gets pulled over by the police officer because they've been drinking, and the police officer asks them to step out of the car and have them do what we call roadside tests. Basically, what that police officer is doing is they're testing your cerebellum. Right? And if the cerebellum is having some dysfunction, right, basically a neurologist or a primary care physician, if they are suspecting that their patient has cerebellum issues, they'll do a roadside test inside their office. They'll ask the patient to walk toe to toe along this line here. They'll ask them to stand and try to balance themselves. So when there is something wrong with the cerebellum because of the ingestion of too much alcohol or certain drugs, you can have problems with walking. You might have an inability to maintain balance and posture. And because of that, those disturbances, you will have a significantly reduced ability to detect any of that corrective proprioceptive biofeedback. So you won't be able to self-adjust to correct. So basically, that's what's going on when you're dealing with the cerebellum for a roadside sobriety test. All right, that concludes the 4 regions of the brain. Now we are going to talk about a couple other parts to the brain. So I figure the limbic system is a great place to start because it has to do with emotions. The limbic system, our emotional brain here. And the limbic system is composed of several different parts of your cerebrum and the diencephalon. And so it's these structures, and we'll go through these structures here in a moment, that are going to process and experience those emotions that are generated. All right, so the cingulate gyrus. Well, first of all, let me just show you a quick picture. Here's our limbic system, right? And you can see, because here our diencephalon is down in here. So our diencephalon is definitely within the limbic system here. So we're going to talk about the different parts here. So I'm going to go one part and show you. All right, the cingulate gyrus, it is superior or above our corpus callosum. That's this kind of pinkish, not pinkish, but purplish structure right here. Here's the corpus callosum. And our cingulate gyrus is right above it. All right, and then we have our perihippocampal gyrus and the hippocampus. All right, so our perihippocampal gyrus is this fellow right here. And then right above it is the hippocampus, superior to that. All right, but our hippocampus, very important that you know what this guy does, plays a role in long-term memory formation. If you damage the hippocampus, I'm sorry, friends, you can no longer form long-term memories. Damage to that is no bueno. Okay, so here's our hippocampus. Let me get rid of. Actually, we'll zoom in. What am I doing? There we go. Okay, so here's the hippocampus. And then below it, there's our perihippocampal gyrus there. Okay, so you damage this area here, you're going to have a difficult time. All right, you will not be able to form long-term memories. All right, some other structures here for the limbic system are the amygdaloid body, olfactory bulbs, olfactory tracts, olfactory cortex, and the fornix here. All right, so the amygdaloid body, this structure plays a large role in emotional and emotion response, including emotional memories here. So if you lesion this area here, you can have very bizarre and crazed behaviors. Right, for whatever reason, and I wish I could remember the name of the condition. It escapes my mind right now. But if you lesion the amygdaloid body, right, these folks can exhibit very odd sexual behavior, but they will have very, very obscene outbursts with a fearful response. All right, so that's the amygdaloid body. So think of the amygdaloid body as the emotional center and emotional memories. Right, now, if you notice this next part, the olfactory portion has to do with smell. So it is because of these structures and how they tie into the limbic system that when you smell something, and I mentioned this last class when we were talking about the habenular nucleus, all right, that was that structure that was part of the epithalamus. So when you smell something and you get nostalgic and you think of somebody because a smell may have reminded you of grandma's apple pie or whatever, and you start to get emotional, all right, well, all right, you can see here how that ties in because the olfactory bulbs and the trach and the olfactory cortex, all of that's part of the sense of smell, is tied in to your limbic system. And then you have a structure here, the fornix. Again, it is white tissue here that is going to connect the hippocampus there, all right, our memory forming segment, to other limbic structures. So I always remember the fornix as just this connecting bridge that would connect parts of the limbic system to other structures there. And then you can see we have several other structures. I already mentioned the habenular nuclei, okay? But again, just the point that I'm trying to make is the limbic system has its figurative hands into a lot of things and a lot of structures in your brain. All right, on to the reticular formation. I told you we'd be talking about this later on. Right, when we were going over the brainstem here, we saw that in parts of the brainstem, we had this gray matter. And there was, and I told you I would talk about this in a little bit. There's two components. Well, first of all, the reticular formation is made up of a motor component and a sensory component. And I do believe I may have told you about the motor component before when we were talking about muscle tone and how somebody like a massage therapist is giving you a therapy session and they're palpating and feel your muscles and they'll say, wow, you've got tight muscles. They're remarking on your muscle tone. And so it's the reticular formation, that motor component there, that is going to regulate that muscle tone. So if we're seeing an increase in muscle tone, then we're going to see an upregulation of the motor portion of our reticular formation here. It also does play some role in our autonomic nervous system here. The other part or component of the reticular formation is our sensory component. We refer to that as the reticular activating system, or the RAS. And this has to do with alertness, right? And so it processes that sensory information. And so depending on what's going on with you determines your level of alertness. For example, like right now, as we're talking, or as I'm talking, and hopefully you're paying attention, your level of alertness should be pretty good. So if someone were to bust into the room and throw a snowball at you, you would be able to hopefully dodge or block it with something. Whereas when you're sleeping, okay, and someone busts into your room, your level of alertness, right, might not be that good, right, because you have to wake up out of that sleep stupor there. And so you'd have to try to protect yourself from that snowball that they're going to hit you with. So that alertness helps to deal with, all right, your consciousness, how conscious are you? Right now, I'd like to think you're highly conscious, but come 5 o'clock in the morning or 4 o'clock in the morning, all right, your level of consciousness and alertness will be much diminished because you're probably going to be sleeping. Right, which brings me into a topic of the levels of consciousness that we'll talk about here in a moment. But you can see here with our reticular formation, right, here's the reticular formation found all throughout the brainstem here. Right, the blue arrows represent our motor input, or excuse me, the sensory input, and the red represents the motor output here. So you can see, all right, how hearing and vision are going to come into the reticular formation, specifically the sensory aspect, to help with your levels of alertness and consciousness here. And then from the reticular formation, all right, it influences, all right, information, all right, nerve impulses to various regions of your cerebrum. Depending on what type of information it is, will correspond to what area of the cerebrum it's going to go to, whether it be vision back here in the visual cortex, or if it's hearing, it'll be over in the temporal cortex. All right, so kind of keep that in mind. All right, which brings me into our second clinical view of the night. Here are states of unconsciousness. So we have fainting, stupor, coma, and the persistent vegetative state. All right, fainting, and I don't know how many of you have ever fainted. I have, only because some kid in high school decided to pull my hair back and cut off my blood flow to my brain temporarily. That was a fun experience. All right, but in that situation, you have a brief loss of consciousness. And in that situation, which happened to me, I had insignificant or a decreased amount of blood flow to my brain, right, which dropped my blood pressure, which caused me to pass out. Right, something a little bit more severe is stupor. Okay, this is when you've seen somebody that may have been in a boxing match, and they take a couple blows to the head, and they're kind of, as you would say, quote unquote, out of it. All right, or they fall down to the canvas there and the ref is counting them out and they're just not even aware of their surroundings. Right, usually what you'll have to do is snap them out of it, quote unquote, you know, maybe slap them in the face. I'm not saying to do that, but you need some sort of extreme stimuli to arouse them out of this state of stupor. We'll see that in several different types of metabolic disorders. Pretty much liver and kidney disease will cause that, and it will cause some of those metabolic disorders. For the most part, a lot of that can be drug induced. Or if you actually sustain, like I said in my example, the boxing there where the guy took a couple punches to the head, he suffered some brain trauma and it kind of put him out of it, so to speak. Coma, if you've seen any real good soap opera worth its weight in gold, right? There's always one character that's in a coma and then comes out of it. Well, when you're in a coma, you are non-responsive. You are in a deep state of unconsciousness. Again, it can happen from, all right, a significant head injury. And in some situations, some physicians will put their patients into a medically induced coma, right? And that's usually to help them to recover from some sort of pathology or illness. Again, we'll see metabolic issues causing coma, all right, a stroke, right? Or if folks get very low blood sugar, like in a diabetic coma, or again, of course, drugs. Then finally, the most severe type of state of unconsciousness is the persistent vegetative state. This is when people have said, oh, that person is brain dead, except for certain brain functions or vital functions to keep you alive. So basically, they have non-cognitive brain functions. That's the functions of the brain that keep you alive. The cognitive are like your thinking, like what we're doing all right now, right? You might see every once in a while, these people will maybe twitch, and some folks will be like, oh, see, they can hear us, they're alive. But no, it's just, in most cases, it's a spontaneous discharge of certain neurons there. All right, we're getting to the end here of the chapter. And so I know in the previous class, you heard me mention, I was talking about the higher order mental functions. And I just want to kind of swing back around, do a little bit of a 360, circle back around to the higher order mental functions and talk about them for a few moments. And how we get to integrate some of those, because a lot of you might be interested in this one specifically, memory. So when we talk about higher order mental functions, we're discussing Learning, part of that is memory, and then reasoning. That's what we're doing all the time. You reason all the time when you don't even think about it. Right, so this is going to occur within the cortex of the cerebrum. What's the cortex? That's the gray matter. Okay, the gray matter of the cerebrum, that's what we refer to as the cortex. And so we're going to talk about all these different areas here about with both conscious and unconscious. Let's talk about sleep first, because probably most of us aren't getting enough sleep. And I would love to find out a way to do away with sleep. I doubt it'll ever happen, okay? But I would love to be able to find out a way. I mean, I love sleep. You're probably listening to a person that absolutely adores sleep, okay? But there's times where I just don't want to go to bed because there's more stuff that I want to do, okay? But then I get tired and I fall asleep. So what happens during sleep? You are going to enter into a temporary state of unconsciousness. So things just slow down. We start to turn all the stuff down. So we're going to see less activity in the cerebral cortex. Now, our vital functions don't change because we got to maintain our heart rate. We got to maintain our respiration and breathing rate and what we call our basal metabolic rate, which are the metabolism of the tissues and the cells to keep those tissues and cells alive. So we've broken down sleep into two stages, right? What we call non-REM sleep and REM sleep. Most of us have probably heard about REM sleep. REM sleep stands for rapid eye movement. So it used to be you could look at somebody when they're sleeping with their eyes closed and you could see their eyes moving. They'd be rapidly moving back and forth underneath their eyelids. And so they were in what we called REM sleep. The non-REM sleep here, right, we start to slow everything down because we're no longer conscious. We start to sleep all these brain waves that we measure using an EEG, which is a device that we use to monitor those brain waves here. We start to slow those down. You spend a majority of your time in this sleep stage here. This is like you plugging in your cell phone at night. What are you doing to the cell phone? You're recharging. Well, guess what? Right? That's what you're doing here in our non-REM sleep. You're recharging. Right? This is where you do a lot of your growing. That's why they always say sleep is important, where we start to reserve or will conserve our energy, but also we are going to restore any of the energy reserves that we depleted during the day. We're going to start to stock back up on that and return those energy reserves back into the proper tissues here. REM sleep, okay, this is when the brain gets pretty active for somebody that's unconscious, right? Like I said, the eyes will oscillate back and forth. You spend this very small amount of time here, and this is how I know I'm not getting much REM sleep, because I can't remember my dreams. Okay, but this is where you get those memorable dreaming. So I used to be able to remember a lot of my dreams when I was a kid. So it told me that I was getting more REM sleep. All right, but I won't know for sure unless I go in for a sleep study. All right, but what I tell folks is REM sleep is when you start to consolidate your memories. So all the stuff that you learned during the day or maybe even the week, right, your brain during this period of time is going to start to consolidate them and pack them together. So you can access them hopefully easier there. Oh yeah, I used to have flying dreams a lot, and I loved those. But then as I've gotten older, I couldn't fly as high, and then I was like the Incredible Hulk. You know, I could only jump for long distances. I couldn't stay in the air and fly. Anyways, I love those dreams. They are fun. Okay, so here it is. If you want to know how much sleep you need throughout your life, here it is. When you're a baby, 17 to 18 hours. I got a friend of mine, he's got a 5-month-old son who's definitely not sleeping 17 to 18 hours, but that's what you need when you're an infant, because that's when you're doing a lot of growing and developing, right? Teenagers, they need 8.5 to 9.5 hours. And that's why it's really important. If you're a parent, don't feel bad sending your teenagers to bed at a decent hour. Problem is, there's studies out there that say that their circadian rhythms are off, all right, and they'll come back to the normal circadian rhythms usually near the end of adolescence. There's some studies on that. But for folks like myself, 7 to 8 hours, and I've even seen 8 to 9 hours. When I was in college, I took an exercise physiology class, and our instructor said that an Olympic athlete needed 8 hours of sleep a night. And I'm thinking, well, if an Olympic athlete needs 8, then I should be okay if I'm getting 7. But it just varies. All right, obviously, we all know that if you're not getting enough sleep, that is unhealthy. It can lead to the following: depression, poor memory. Because remember, poor memory, why is that the case? Because, hello, this is when you are supposed to be consolidating your memories, is during your sleep, during the REM phase. And so if you're not getting enough, you're going to impact your memory. That's why, hello, everybody, right now, pay attention. It's important that you get a good night's rest before your test. All-nighters do not, it might make you feel better afterwards, okay? But you will be better served if you are getting much better sleep during that time. Because when you're sleeping, your brain is going to be taking that information that you were studying, and it's going to put it in places, hopefully, that'll make it much more easier for you to access that, all right, when you need to do memory recall, which we'll talk about here in a few moments. And then, of course, especially now with all the talk of COVID, well, if you're not getting enough sleep, you are going to significantly impact your immune function. You can reduce your white blood cell count, and that's not good. All right. We have insomnia and sleep apnea is some of our issues with sleeping. Insomnia is when you're having a tough time falling or staying asleep. As we get older, this is definitely the case. And sleep apnea is when you're having issues, all right, with your breathing, and so much so it can cause you to wake up several times during the night. And in some cases, if it's pretty significant and severe, you can stop breathing for extended periods of time. I read an interesting article where the author was saying that they had to spend a summer sleeping in the same room as their grandmother or grandfather, I can't remember. And they would lay there in bed listening to their grandparent sleep, and they would count the time in between each breath that they would hear the person take as they were sleeping. And sometimes their count got up to 30 to 40 seconds, and it made them very, very nervous. So what we do for folks with sleep apnea is we give them this cool contraption called a CPAP. It stands for continuous positive airway pressure, and basically it helps to force air into, all right, their respiratory system. And it's been shown that folks that address sleep apnea early on, get a CPAP or have it taken care of, whatever the cause is, will add significantly more years onto their life expectancy. That's a true statement. All right, cognition. What is cognition? All right, cognition is when we're combining all these different terms like awareness, memory, perception, critical thinking, information, wisdom, knowledge, all right, all together. And so what we're going to do is we're going to deal, all right, with the association areas that are located throughout the cerebrum. For example, we see here, right, in the frontal lobe, right, that our personality, critical thinking, planning, decision-making are all found in that region there. So if you damage that area, then you will see all of those traits, right, they can become compromised. If any of you have ever taken a psychology class, you may have learned about the guy, Phineas Gage is his name. He lived back in the 1800s. This poor man worked on the railroad, and he suffered an accident involving dynamite. And what had happened was this huge spike had shot through just underneath, I believe, his left eye and shot out the top of his head. And it damaged his frontal lobe. Prior to this accident, the man was a kind, gentle human being, very nice person. After the accident, his behavior became irrational. And so it changed his personality. And so this is where we started to come up with the idea that if we study certain areas of the brain, it'll help us to understand the normal functions of those areas of the brain. And so that was one of the first, not a study, but first cases in which we learned that the frontal lobe had to do with personality traits. All right. If we damage our primary somatosensory cortex, then we are not going to be able to sense the sensory input that's coming from the contralateral side of our body. So if you've damaged the right primary somatosensory cortex, and if I put in your left hand something that's very obvious, all right, I know I used the ball example. I'm trying to think of something that everybody would know the feel of, and I'm drawing a complete blank. Car keys, for example. I put the car keys in your hand and you're feeling it and you're feeling it and you're like, I have no idea what these are. Okay, that's another way that we're able to help explain the normal function. I'm not sure if you folks have ever heard of the term agnosia, right? But what happens is when you have a condition with agnosia, that is when, all right, you are unable to recognize or understand what the stimulus is, right? Like that example that I just told you, right? You damage that somatosensory cortex, you won't be able to tell what it is in your hands. Or if we damage the temporal lobe, oh my gosh, the temporal lobe in regards to hearing, okay, you won't be able to understand, right, what it is, all right, that folks are saying. Okay, you can hear, but you might not understand the meaning of those words there. Okay, memory. Now let's learn a little bit about memory. So there's three types of memory. We have sensory memory, short-term and long-term. Now, most of us are familiar with short-term and long-term memory. Long-term is that's the permanent memory, all right? That's the stuff that you may have that you remember, all right, the name of your kindergarten teacher. That's long-term memory, all right? Short-term memory lasts for a couple hours. Maybe you saw an episode of The Bachelor and some specifics happened in that episode. You go to talk about it the next day, you're fine. But like a month later, someone asks you, hey, tell me about that episode again. And you're like, huh? Yeah, I kind of remember, right? So that's your short-term memory. Sensory memory, this is what happens almost all the time, all right, when we're talking about sensory input, okay? Sight, sound, touch, smell, right? This memory lasts for a very short period of time. But sensory memory is hoping to gain access to short-term memory, and then hopefully we can take that and put it into our long-term memory. So I'll show you here, okay? So when we talk about our short-term memory, like I said, it is limited. It only lasts for a short period of time. But this is where a lot of studying has gone into, all right, learning. And we talk about the bits of information. That's why I recommend to students, when you folks are studying things, if you say, all right, I'm going to sit down here and study for a half an hour, then I would say, all right, get 7 flashcards. Okay, 7 bits of information. And during that half an hour, go over those 7 bits of information and take a break. And then come back and look at them again. If you know all 7, then you can get 7 other flashcards and start with that. Now we're going to move into and talk about how we get information to transition from short-term memory to long-term memory, because that's where this term comes into play, in which we encode, all right? And when we encode something, we take it from the short-term memory, and if we've repeated it enough times through the encoding process, then we can hopefully indefinitely possess that information. And hopefully we won't lose it, and we can retrieve it whenever we need to. So I love this picture here, okay? This is how we're going to process that information. So you have some sort of stimulus, okay? It can be a light stimulus that your eyes pick up, or it can be a touch stimulus that your sensory receptors pick up in your hands, or it could be hearing, regardless, right? When you perceive, when the receptors for whatever that stimulus is perceives it, it immediately becomes sensory memory. It lasts for a brief moment. So if you're actually paying attention to it, okay, it might then transition into short-term memory. Now, the more you repeat that, okay, and I'll give you an example here in a moment. The more you repeat it, the higher your chances are of encoding that information and putting it into long-term memory. So when you need to retrieve that information, hopefully on a test, okay, it will be brought here to your short-term memory, and you can answer the test with that information, hopefully correctly. All right. If you see something, you're not really paying attention, there's a high possibility you're going to forget it. Same thing with short-term memory. All right. If you are putting stuff into short-term memory, but you're not repeating it enough time, you decrease your chances of encoding, and there's a good chance you'll forget it. If you put something and you're successful into the long-term memory, but yet you don't retrieve it for a long period of time, okay, again, you increase your chances of forgetting it. So there's a saying out there, if you don't use it, you lose it. And there's a certain amount of truth to that, okay? So when we talk about the encoding, look at this term up here. Wait a minute, memory consolidation. That looks familiar. You're darn right it looks familiar. You know why? Right here. Here you go. REM sleep. There you go. Another reason why sleep is important, specifically REM sleep. That's when you consolidate your memories. That's when you take that information, okay, from the short-term memory, and then you put it into the long-term memory. Right? You heard me talk about the hippocampus. That's that structure in the limbic system that has to do with long-term memory. Also, our amygdala will also play a role in encoding. All right, so I hope you're kind of seeing all this. You know, this is kind of like a public service message that I'm doing for you. All right, I want you to see the importance of what sleep is for you when it comes to memory. It's only going to help your studying and your success in class. So long-term memory, all right, is going to be primarily located in, this is important, the appropriate association cortex area. Okay, perfect example, sound memories, right? They're going to be stored in the auditory association cortex, right? Visual memories will be stored in the visual association cortex. So that's what we're trying to do. Motor memories, okay? When you're learning how to juggle, those are going to be stored in the premotor cortex, but also don't forget about me, buddy. There's the cerebellum. That's our fine tuning area, which also has storage capacity. Okay, that's why these association areas are important, because they are going to house that long-term memory, depending on what sense we're talking about. If it's a visual sense, it's a touch sense, if it's an auditory sense, a taste sense, whatever, it'll be stored in the appropriate association area. Which brings me to our third clinical view, Alzheimer's disease. There's a movie called The Long Goodbye. I've never seen it, okay? But if you're interested, something that I don't like to watch sad stories, okay, unless it's Field of Dreams. All right, but Alzheimer's disease is a form of dementia. We do see it in our older population. In case you're not sure what it is all right, it is a slow and definitely progressive loss of higher intellectual function, but not only that, in advanced stages, all right, we will start to see, all right, actual motor function loss and other functions that occur. My grandmother had Alzheimer's disease. And so it started off with her kind of just forgetting things. You'll start to see, you know, changes in mood and behavior. Might start to forget something, or they might just get mad for no reason, or do something that's just not out of character. You hear it all the time. I listen to the local news all the time. You'd be surprised how many people go missing here in Greenville, South Carolina. You would be surprised. They'll just walk out of their home and just start wandering around. Hopefully they won't go into the woods, but we'll start to see, all right, this loss of memory, these changes in personality. All right. Now, when I was in med school, there was a lot of study on the beta amyloid plaques and these protein tau tangles. Right? Nothing conclusive really has come out yet that's definitive. Right? So we still say that the cause of Alzheimer's disease is still idiopathic. It's unknown. We don't know. But we do have some theories that it might be this plaque buildup in the neurons there, or these protein tangles, okay? But it's still up in the air. We have seen some medications help with that, right? But what we have noticed, which is really interesting to me, is that if you see a loss of smell, now that's kind of tough to deal with now with COVID, okay? But if we see an early loss of smell, then it's considered, to be a possible early sign of Alzheimer's disease. All right, so what about amnesia? You'll see it in TV shows and cartoons. You hit somebody on the head and they forget who they are, okay? So amnesia can be either complete or partial loss of memory. Hopefully it's temporary, but in some cases it may be permanent. So you can have a direct brain injury or some sort of psychological trauma. We see it all the time in child abuse victims, folks that were abused as a child that totally forget it because they have blocked it out and they have no idea, right? So amnesia, partial or complete. And now, if there's some sort of physical trauma, it depends on where that trauma occurred. Remember, when I told you, if the hippocampus is damaged, then we are unable to create long-term memories. But also, if we damage the thalamus, because you know what the thalamus is, right? The thalamus is the relay center. If we can't relay that input information to those association areas, guess what? You might not be able to form some of those long-term memories for muscle memory or for visual memory, okay? And we'll also see it with our limbic structures, specifically the hippocampus. Speaking of the limbic structures, emotion, real quick here, right? When we're talking about emotions, that involves the limbic system. But that's how we interpret the emotions. When we express the emotions, what do you see when someone's mad? They might scowl on their face. Well, what causes the scowl on the face? The facial muscles. What are the facial muscles? Skeletal muscles innervated by our primary motor cortex, influenced by the pre-motor cortex. So that comes from the prefrontal cortex. So you talked about, when we were talking about the limbic system, damage to the amygdaloid body or the hippocampus can impact how we respond and interpret emotions. So in some cases, you might get what we call a dead affect, which is, hey man, guess what? Congratulations, you just won $1 billion. And that person, normally, if it were me and you told me that, I would probably hug you and start screaming uncontrollably. But this person would be like, great, I am so happy. This is the best day of my life. And they'll just stand there and then maybe walk away. Or, right, you tell somebody, hey, can you do me a favor? Can you pick up that piece of paper for me? And they just go off on you and scream at you and just react crazily, right? So you can have one or the other there. I do want to finish up here and talk a little bit about language here, just to kind of, I know I've talked about it last class, but might as well finish up here and discuss when we're just talking about language. I'm talking about not only me speaking to you and you hearing me, but also, and understanding what I'm saying, but also when you're reading, like in your textbook, or even writing out your notes. So areas of your brain that play a role in language are going to be Broca's area and Wernicke's area. All right, Wernicke's area sits more back in the parietal lobe. That's back here. All right, and so that's going to help with language interpretation and comprehension, the understanding. If you were to lesion that area, when I'm talking to you, you would hear my words. They'd make no sense to you. You just wouldn't have any clue as to what I was saying to you. I mean, you'd still understand English, you just wouldn't understand their meaning. You would not be able to comprehend. Now, you have Broca's area. That's in the front, in the frontal lobe here. All right, if you were to lesion Broca's area, motor speech would be affected. You would be having issues. Now, you could think fine. You could think the words in your head, all right? But when you started to say the words, it would just be incomprehensible. And so that would be our motor speech area there. So, of course, we talked about our categorical and our representational hemispheres here, right? It's the core categorical. Geez, I cannot talk tonight. The categorical hemisphere is going to be the hemisphere that is going to analyze the meaning of speech there. Whereas the representational one, that's when we start to get emotional. So if you were to lesion, all right, your right hemisphere, then you can get what we call aprodosia, which is that emotionless speech, kind of like what I was trying to impersonate earlier when I told you that you won the lottery. Okay, they would. Let me just say this: you would not want to have a teacher, and maybe some of you have had a teacher that maybe sounds like they have aprodosia, right, where they're just very monotone and flat. Okay, apraxia is that motor disorder. Okay, like I said, they can understand what they're saying, but they just can't say it correctly. All right, aphasia is when you have difficulty understanding or producing. All right, and then finally, the last clinical view is dyslexia. I had a roommate in college that had dyslexia. All right, so they had issues with just single word decoding. And let me tell you something, it was very stressful to have my roommate ask me to proofread his, this is back, now mind you, in the 90s, right, where we didn't have spell check. Maybe we did have spell check then, but we didn't have spell check and grammar check like they are now, okay? So he would ask me to spell check and grammar check his papers. And I just felt like it was a pretty big responsibility, because then I could be impacting his grade because I wasn't the best at writing papers. All right, but these folks will have issues when they're reading and writing and spelling out words here. Now, here's the thing, okay? Folks that are dyslexic, they don't have reduced intelligence. And in fact, all right, some of these folks that have dyslexia may excel in other areas. Now, granted, reading and writing and spelling might not be very good, but their ability to speak. My roommate, for example, he was a very articulate and eloquent speaker. And so it's like a blind person gets better at hearing, okay, because other senses kind of step up a little bit. Here with my roommate, you know, even though he'd have issues with, you know, with his dyslexia, his speech, his ability to articulate words they were great. They were great. And the crazy part was, I know it says the level of reading competence is below the expected intelligence. He read books all the time. Right. So there's ways to overcome and adapt. And that's my point. And that's what happened with my roommate. All righty, folks, that's it. That is the end of chapter. I'm really surprised.